So my name is Lara Wadi, and I'm one of the second-year neurology residents, and here is my case. So I am presenting the case of a 71-year-old man who presented with a 4-day history of progressive vertigo, nausea, gait instability, and urinary retention. And his social history was notable for significant smoking, alcohol use, and hunting and tree climbing. He was evaluated at an outside hospital, and his pertinent findings on his initial exam were essentially a positive Dix Hallpike. He had an MRI of the brain, which was unremarkable. Unfortunately, due to worsening symptoms, he ended up hospitalized, and his hospital course was characterized by low-grade fevers, episodes of supraventricular tachycardia, tachypnea, and on day 3, he developed acute encephalopathy. And now his exam was notable for disorientation. He was opening eyes, noxious stimulation only. He was noted to have dysarthria, which eventually progressed into unintelligible moaning. He was now noted to have irregular eye movements consistent with opsoclonus, and went from following commands in all 4 extremities to only withdrawing to noxious stimulation. And so he was covered empirically for meningitis, got thiamine supplementation given his alcohol history, and that didn't really improve his symptoms. He got an LP done, which was consistent with mild lymphocytic pleocytosis, and an extensive infectious workup given his hunting history, thinking of potential exposures, which was unremarkable. Because of worsening tachypnea and a worsening neuro exam, he ended up in the ICU and he ended up intubated. He got another MRI brain, now with and without contrast, which was unremarkable. He was even put on prolonged EEG, which showed no seizures. And at this point, there was a concern that this could maybe be a paraneoplastic syndrome. And so a CT of the chest, abdomen, pelvis was obtained, which showed a right middle lobe mass, in addition to mediastinal and hilar lymphadenopathy. And so the next day, he actually got a bronchoscopy with biopsy showing small cell lung carcinoma. And 3 weeks later, his autoimmune encephalitis panel comes back with positive anti-Hu antibodies. And so I'm going to discuss the anti-Hu paraneoplastic syndrome here briefly, which I find interesting. And it's basically characterized by the presence of Hu IgG antibodies, which are polyclonal antibodies that target an intracellular antigen, typically RNA binding proteins, the most common being Hu-D, which are implicated in post-transcriptional regulation of RNA in neurons. Hu IgG are the most common paraneoplastic antibodies, and it's thought that Hu antigens are expressed by the underlying tumors, such as small cell lung carcinoma, for example. And here's an interesting illustration of immunohistochemistry staining, where essentially we see that immunoreactivity of the Hu IgG antibodies is confined to the neuronal nuclei and granular and molecular layers of the cerebellum. And what's interesting as well is that it's an antigen-driven cytotoxic T-cell response. And so here is a suggested simplified model essentially behind the immunopathogenesis of this paraneoplastic syndrome. So the immune response is thought to originate in peripheral lymphoid tissue, where we have dendritic cells that capture tumor-derived antigens, such as Hu-D, and this is just an example. These dendritic cells end up in tumor-draining lymph nodes, where the tumor-derived antigens, such as Hu-D, are processed and presented by antigen-presenting cells to activate specific CD4 and CD8 plus T cells. What's interesting is that certain cancer cells are able to express MHC class 1 molecules in addition to Hu-D derived peptides. And so this way they become targets for a CD8 plus killer T cell response. And this is thought to be a mechanism to potentially limit growth rate of the tumor. Unfortunately, in parallel, some of these activated T cells circulate and gain the capability to cross the blood-brain barrier. So moving over to the CNS, we have neurons that are able to express MHC class 1 molecules, and under the right inflammatory conditions or milieu, they're also able to express Hu-D derived peptides. And so the neurons here become attractive targets for a CD8 plus killer T cell response. And so through the release of things like granzyme B and perforins, we end up with apoptosis and neuronal tissue damage. And so going back to the anti-Hue paraneoplastic syndrome, typically when we have presence of Hue IgG antibodies in the setting of a paraneoplastic syndrome, it's commonly associated with the presence of an underlying malignancy in the majority of patients. The most common being small cell lung carcinoma, but this can also be seen in the setting of neuroblastoma or prostate cancer. And the paraneoplastic manifestations really vary. For example, we can have cerebellar degeneration, as was seen in our patient. So patients can present with gait instability, ataxia, dysarthria, oscillopsia. CSF tend to show signs of intrathecal inflammation. And interestingly enough, brain MRIs can be unremarkable, as was seen in our patient. Other manifestations include sensory neuronopathy, which is most common, and then limbic brainstem encephalitis, encephalomyelitis, and dysautonomia. The presence of a paraneoplastic syndrome or its diagnosis often predates the discovery of a cancer with a median delay of 3 months. And so moving over to treatment, this typically relies on two main pillars, the first being anti-tumor therapy. The earlier, the better for disease stabilization. And I've read mixed reports really about immunosuppressive therapies with unclear efficacy, trying corticosteroids, IVIG, Plex, cyclophosphamide, and even rituximab. Unfortunately, however, outcomes tend to be poor, with median survival between 7 and 13 months. And common causes of death usually are autonomic and respiratory failure. So going back to our patient, he got high-dose steroids for 5 days. He got 2 treatments of plasma exchange with no improvement. Ultimately, it came down to multiple goals of care discussions with the family and oncology, who felt like the patient would not be a good chemotherapy candidate, just given the fact that he was intubated with such a poor mental status. And so the decision was made to focus on comfort measures, and this resulted in a one-way extubation. And unfortunately, the patient passed away. And so this was my case. These are the references that I used. And thank you for your time. That's it.
Thank you so much, Lara. Well, that's a bit of a downer. None of your patients, that doesn't happen in any of your patients, Lisa, I'm sure. All right, again, to CME. So, you know, it's truly my distinct honor to have Lisa Christopher-Stine here. I've known Lisa for a long time, when she was just a pup. And Lisa is one of those people I talk about all the time whose, you know, individual passion has driven an incredible program. She was the founding director of the Hopkins Myositis Center, which I think I can say is the go-to place for people with inflammation and autoimmune myositis. She has a database now of 1,000 highly phenotyped myositis patients, which is continuing to pay off. She, along with Andy Mammon, described and characterized the anti-HMG-CoA reductase associated autoimmune myopathy. And Lisa now is working quite a bit on systemic sclerosis associated myopathy, along with many other projects. You know, the collaboration, when I first met Lisa, I couldn't believe what she told me, which was actually that rheumatologists see most of the myositis patients. And I had assumed that neurologists did that, but then Lisa put her cohort next to the one that Andy had established, and it was about a 10-to-1 ratio. So indeed, rheumatologists do see far more myositis patients than neurologists. And one great thing about the Myositis Center is the neurologists and the rheumatologists actually started talking to each other and started comparing treatments. And it was an incredibly powerful thing that happened. And I was thrilled to just be a bystander and watch this all happen. So Lisa's talk today is going to be Myositis 2021, Moving Beyond Dermatomyositis and Polymyositis. So Lisa, I'll turn it over to you.
Thanks so much, Rich, and good morning to everyone. In these unusual times, I think one of the, silver linings of the pandemic is that we can travel from the bedroom to the office, or the bedroom to our home office in a very quick amount of time, and I can be there with you in the South. So it's great. I do miss you, Rich. I miss I am sure all of you have gotten to know the unique individual that is Dr. Rich O'Brien, and you are definitely missed around the clinic for sure. Let me just see. Hopefully this will work. Okay.
Yep, it's working.
Okay, and let's go. Okay. Am I now sharing? Yeah. Okay. Can you see the slides, and are they moving?
Yes, all good.
Okay.
Yes,
Okay.
yes.
Thank you, thank you. Okay, and you can hear me, so we're good. So I actually entitled this, moving beyond dermatomyositis and quote polymyositis. And I'll point out in my title that I'm an associate professor of medicine and neurology, and I'm definitely not a board certified neurologist. That's a joint appointment from which I am very grateful for the Department of Neurology. I am a rheumatologist, and as Rich said, it's extraordinary what happens when two disciplines talk to each other. And I've always maintained that some of the best discoveries and the best care of patients have occurred because we are a multidisciplinary center. I have learned so much from my neurology colleagues. And at the end, I'll show you what we look like. We've grown from just 4 of us at the start of the Myositis Center, which opened its doors the first week of March in 2007, if you can believe that, Rich, which is impossible to believe that we're on year 14 of this experiment. And Rich also is quite humble. Without him and his leadership, there would be no Myositis Center. So I always say that Rich was the grown-up in the room when we had this idea, but without his backing, I wouldn't be speaking with you today. So I am really, truly grateful for his leadership and mentorship. So with no further ado, my disclosure. So today, in a short amount of time, I will review for you not only the idiopathic inflammatory myopathies, but this sort of genesis of over time of what's happened with nomenclature. And I'll show you that it probably goes well beyond just nomenclature, in that it's important how we phenotype. And then really we're starting to recognize that our phenotyping is also correlating, even at the molecular level, something as fine as RNA-seq. We'll look at this concept, my favorite concept, and I have to tell you, this was taught to me by neurology. The original paper and editorial were by neurologists that infuriated rheumatologists that said, this is not true. I have to tell you, I think it's true. So I hope by the end of my talk, you believe me that probably despite the fact that my papers use the word polymyositis, the title of this talk has polymyositis, I really hope that I don't use that term in the next few years, because we're getting better at knowing what that really is, or use it very seldomly, I guess. Then briefly, I'll show you, and certainly as a rheumatologist, show you how autoantibodies stratify and help diagnose patients. So again, this isn't really an academic exercise, because if we know the autoantibodies, we can often not only phenotype patients well for research studies, but we can help predict the possible associated features that are coming down the line for them. And I always like to be reactive rather than, actually proactive rather than reactive, not having to be surprised. And then in the interest of time, I don't think I'll be able to do this in great depth. This is a talk unto its own, but I wanted to at least briefly outline current clinical trials, ones that are published, ones that have not been, and then what's in the pike for myositis, and then briefly the way that we treat today. Okay, so with no further ado, on the left is the way that myositis was described to me shortly before I joined the effort to help build the Myositis Center along with my neurology and pulmonary colleagues. It was this: polymyositis, dermatomyositis. That's it. Over the years, we're appreciating a much more fine phenotype. And you can see on the right, in addition, so, okay, maybe there's polymyositis. I'm going to submit to you that that is not this giant blue square on part of the pie on the left, but rather the tiny little orange part of the pie on the right. Dermatomyositis makes up a fair amount of our patients still. The overlap syndromes, Rich spoke about systemic sclerosis. Our group has a strong interest, along with my mentee, Julie Peck. We look at the overlap between scleroderma and myositis, but also rheumatoid arthritis, lupus, Sjogren's syndrome, and RA. Inclusion body myositis. This wasn't even appreciated in the beginning of the descriptions of myositis. Nobody recognized how to distinguish that from polymyositis. And I'll give a short histologic comparator. Again, for this group, you are all the experts under that microscope. You've taught me all of this. but I'll just review for you why maybe the rheumatologists sometimes get confused. And I think now we all understand that we've probably misdiagnosed polymyositis as IBM for years. Cancer-associated myositis is rolled into many of these, like DM, for example, sometimes in the overlap syndrome. So it can stand on its own or be part of those other in those other groups. And then finally, the anti-synthetase syndrome that really is its own phenotype. Again, we can see the rash that looks phenotypically identical to what we would call dermatomyositis, and these patients are still called dermatomyositis. The patients recognize that term. I sometimes use it because the rash is so similar. But at the molecular level, at the level of sequencing RNA, at the histology level of using muscle cells, I'm going to show you that the likelihood is that it's a different entity, and we should treat it as that. Okay, so I'll briefly review classification criteria, not to torture you, but just to remind you of where we've been, and where we're going. And to be honest, these criteria stick, even though they're imperfect. So back when I was in kindergarten, the Bowen and Peter criteria were developed, and they stuck there really for 40 years, almost all of my training time and yours, and some of yours who are on the screen who might be in my age group. So symmetric proximal muscle weakness, elevated muscle enzymes. I always remember to remind myself that transaminases are muscle enzymes. I've had at least 8 to 10 of my patients have 2, not 1, but 2 liver biopsies before anybody realized their AST and their ALT was actually of muscle origin. Myopathic EMG abnormalities, that is your forte. Typical changes on muscle biopsy and the typical rash of dermatomyositis. So these easy classification criteria said if we had all the first 4, that's definite polymyositis. If we have only 3 of them, it's probable. 2 of them possible, and certainly as the fewer criteria you get, the less sure you are of this. And then if you had the typical rash of dermatomyositis with 3 of the 4, so in other words, you didn't really need a muscle biopsy technically, or you didn't necessarily need an EMG, you could have 3 of the 4 along with dermatomyositis and have definite dermatomyositis. What you don't see here is any inclusion of IBM. You certainly don't hear anything about immune-mediated necrotizing myopathy, the new kid on the block in the last 18, 20 years. And then you don't see amyopathic dermatomyositis talked about much at all. So after 40 years, we have progress, maybe. Okay, so as Rich said, we talk about this in our clinic. Who's better at, I think that our partnership was wonderful in that we stopped fighting about who diagnosed it better, who took care of it better. Certainly, I think that neurologists and rheumatologists have complementary skills, and we can learn from one another. So it really was not lost on me that I felt like when we started this clinic, we were on different planets, and thus the editorial. I might have borrowed the title just a little bit, but neurologists are from Mars and rheumatologists are from Venus. The way that we classified the idiopathic inflammatory myopathies was clearly developing, and I'll tell you a bit more of that story. But it was really the neurologist that started using this term immune-mediated necrotizing myopathy, or NAM, necrotizing autoimmune myopathy. And every time we would say polymyositis, someone else would say, we would say polymyositis, the neurologist would say, no, I think it's IMNM, and we'd say, what's that? So that is the genesis of what's happening. So from Venus. So here is actually, and to be honest, this is also has contributors from neurology as well. So the European and American rheumatology bodies got together, and this really was a 10-year effort to try to make a classification criteria that used a calculator. So instead of plus minus, it really was sort of a continuum where there would be a score range and there'd be a probability of myositis. And you wanted to see at least a 55% probability. And I'll show you how that works. Without belaboring this too long, just know that from the Bowen and Peter criteria, what do we carry over? We carry over this idea of weakness for sure. But instead of just saying proximal, it's separated now into proximal upper and proximal lower. Now they add in neck flexors, weaker than neck extensors. And then looking at the pattern a little, then they say, well, what if in the legs, proximal muscles are relatively weaker than distal muscles? Trying to tease out the difference between quote unquote PM and IBM. And then all of the rashes from the original criteria are there, but they're defined a little bit more closely. I'll just review a very brief slide of the pathognomonic rashes, but that's heliotrope, Gottschon's papules, where it would be palpable, Gottschon's-Stein, where you would not be able to feel the rash. And then dysphagia is added into the criteria now. You'll notice the only autoantibody in this criteria is anti-Jo1. And we have numerous autoantibodies, but yet Jo1 is the only one that makes the list, because when this whole criteria scheme began to develop, Jo1 is the only widely available autoantibody. That has since changed, and likely these criteria require update, because myositis-specific antibodies are quite specific and would be very helpful in adding them to these classification criteria schemata. So stay tuned, I think, for another update. And then obviously all of the changes on biopsy, and as well as the elevated enzymes. And you'll also notice here, the very first criteria is age. So the Bowen and Peter criteria did not make a distinction between juvenile and adult onset. And the reality is, while we characterize 18 and over as adult onset, and up to age 18 as juvenile myositis, again, I really think it's largely a continuum. The phenotype I see in young adults in their early 20s look a lot like kids who could be 6 or 7 years old, a lot of calcinosis, similar rashes. So it's not as if it just stops at age 18 and suddenly you have the adult form, but for purposes of classification, that's how this schema looks. So if you meet that classification criteria and you are younger than 18, you go to the right side of the slide, and that's asking, do you have a rash or don't you? And the broad classification criteria in kids is this JDM? Is it juvenile dermatomyositis, or is it something else? And you see those 3 little asterisks. That suggests that they have this, again, wastebasket category that's called juvenile myositis other than JDM. That's based on expert opinion. And certainly my colleagues at the NIH, including Andy Mammon, who was mentioned at this talk, who co-discovered HMGCR autoantibody along with me, he and his colleagues, pediatric colleagues there, have shown that a lot of juvenile patients who are either mischaracterized as a muscular dystrophy as kids, and sometimes called quote unquote PM, really have immune-mediated necrotizing myopathy, often with the HMGCR autoantibody. On the left, we say, okay, what if you're an adult? Then again, the cut point is, do you have a rash or don't you? If you do, then we look at all of the objective measures for weakness. If you are weak, you have dermatomyositis. If you're not weak, there is where we finally make the distinction. Our dermatology colleagues are delighted that we finally talk about amyopathic dermatomyositis. I'll show you later that it's not as if because you don't have muscle involvement, it's not serious. Believe it or not, it may not come to the neurologist's purview as often, actually not even the rheumatologist. A lot of our dermatology colleagues are the first line of defense and often follow these patients longitudinally, but it's important to know that this can certainly present, dermatomyositis can present amyopathic. It's truly amyopathic if in the first 2 years, we don't see the development of muscle disease. And often my patients will say, what is the chance I'll stay in an amyopathic category? We haven't carefully been able to do this in our cohort. It's a question I've asked, but just my gestalt and sort of the literature suggests that about 20% of patients stay in the amyopathic category and don't progress to muscle involvement. On the far left, we ask for these clinical features. And then again, I'll direct your attention to the right side of the slide. There's this little asterisk that says, is there finger flexor weakness, or they're not improving to respond to their treatment? Then we're talking likely about IBM. Similarly, are there rim vacuoles? Yes, IBM. It's a little bit dicey because, as you know, you can tell me this more than I can tell you this, that often we don't see rim vacuoles under the microscope for IBM, even if we biopsy them 3 times. That may be sampling error. That may be something we don't understand, and not every IBM patient actually develops those vacuoles, or it was missed, which has happened more often than not, and then has to be reread. And then finally, if you don't have any of those things, then you fall into the quote PM bucket. And you can see in parentheses, immune-mediated necrotizing myopathy, there really were too few to allow subclassification. And one last thing I will say again, and I won't belabor classification anymore, but I really need you to understand what the stage looks like by the way we think about these diseases before I can further phenotype for you. One other thing to mention is that between amyopathic dermatomyositis and truly myopathic dermatomyositis is hypomyopathic DM. And that says that, well, there really are subtle features of weakness, or maybe they have an elevated CK, but they're not quite weak yet. Or we do an MRI and we see muscle edema that is not thought to be due to denervation or another reason for edema in the muscle. It's true myositis. In that case, we say, they likely will develop weakness, but we still call them hypomyopathic. So they're not quite clinically weak enough to call myopathic. All right, how about from Mars, our neurology colleagues? So this is one of the neurology groups who has looked at one of their own retrospective cohorts from 2003 to 2016, and they were able to look at about 260 patients who had complete data in their cohort of about 400. Suffice it to say, they did some statistical analysis which included unsupervised multiple correspondence analysis. They cluster and use hierarchical clustering analysis to try to subgroup. And their analysis said, look, there are 4 group clusters, and they're dermatomyositis. Now, there are 5 dermatomyositis autoantibodies, but in their study, they used TIF1 gamma, also known as P155-140, MY2, and MDA5, and that clustered together. Then IBM was its own cluster. Immune-mediated necrotizing myopathy, which was identified by the 2 main known autoantibodies, HMGCR and SRP. And then finally, the anti-synthetase syndrome. Again, in their cohort, there are 8 synthetase autoantibodies, but they only had JO1 and PL7. So to be clear, this is sort of this tension, like, do we group by autoantibody? Do we group by phenotype and clinical characteristics? Our own group has actually done a similar analysis, which is not yet published, and it actually does look more like it comes from Mars. So I think we're going to be a little bit more in the neurology camp of this neurology study. And so stay tuned, I think, for even more distinct phenotyping and better classification. So if you're a clinician listening to this and not somebody in the lab, and you say, well, look, or maybe you're a medical student, which is joining today, what kind of things will you think about when you see your future patients? What points away from the diagnosis of myositis? What's remarkable is, in general, a family history of a similar illness. I have only 2 patients in my cohort. I now see myself I'm probably close to 1,000 patients, about 800. Our entire cohort now, with all of our colleagues, numbers 2,600. And family history is, I can count it on one hand. I often don't believe it. If I see a family history of a similar illness, I'm almost always thinking about a dystrophy or something else entirely. Weakness related to eating or fasting is usually a metabolic signal that we're looking at a metabolic myopathy. Here's you guys: sensory reflex, other neurologic signs, cranial nerve involvement, almost never. Fasciculations, occasionally, but if they're dominating, I'm certainly thinking of denervation syndromes. And unfortunately, every rheumatologist in our clinic has made the diagnosis, along with our neurology colleagues, confirming it, of ALS. It often mimics myositis, certainly in its early stages. Severe muscle cramping, again, is distinctly unusual. We see occasional leg cramps. Prednisone can be associated with cramping, but when cramping dominates, again, this is when I phone a friend and say, this looks like, I often say it looks neuro-y, looks neurologic or something else. And then early atrophy, except for a few notable exceptions, again, very atypical. CK is on either side of normal or the upper limit of normal. So suffice it to say that if I see something in the CK range that's 100 times the upper limit of normal, I'm almost always thinking about a metabolic myopathy. Now, I will make one distinction that CK is under 2 times the upper limit of normal. Generally, the only time that I'll allow this is dermatomyositis. And dermatomyositis can absolutely present with a normal CK with whopping amounts of inflammation. That is, again, a little clinical pearl that it took me years to understand. It might likely stems from the fact that the inflammatory response does not necessarily produce a brisk CK leak into the serum. That occurs with necrosis, most likely. So our working hypothesis of why low CKs can occur in dermatomyositis with very, very weak patients is that there is likely not there's not domination of necrosis, that it's more inflammatory, and inflammatory infiltrates in themselves don't usually produce a high CK leak. So, okay, what points toward the diagnosis of myositis? The characteristic rashes, which I'll show you in just a minute. This is a gradual onset. This is not like I woke up Tuesday and had myositis. Occasionally, patients do actually say that. That is the exception and not the rule. If a patient tells you they were normal last week, they felt fine, and this week they can't walk off the chair, they can't stand up the chair, think of something else. Proximal limb and truncal weakness, of course, and then other connective tissue disease features. So maybe as neurologists, I'll just ask you to think more about somebody and ask them about Raynaud's phenomenon, even esophageal dysmotility, which can be part of other neurologic symptoms, but is often part of our rheumatic diseases. And then finally, arthritis. This is usually an inflammatory arthritis that's symmetric. And I would have told you it was non-deforming, but I see arthritis that looks exactly like rheumatoid arthritis. And I cannot tell you the number of patients that start with the diagnosis of RA. They almost always come to our purview and have the antisynthetase syndrome most often. So it's an additive syndrome, and so sometimes it's the very first feature. And then, of course, lung disease. And what you didn't see on any of the classification criteria slides is anything named antisynthetase syndrome, never talked about lung disease. So while we finally pulled in our dermatology colleagues, we have forgotten our pulmonary colleagues. And in interstitial lung disease, and I will say, if you are cooking your breakfast, walking your dog, trying to pay attention to this lecture in this virtual world, there are a few things where I'll ask you to remember what I said. And if you remember nothing much other than please check a CK if the liver enzymes are elevated, simple things. And if you see interstitial lung disease, especially in a young woman of color, please don't call that idiopathic lung disease until you've checked all the synthetase antibodies. I cannot tell you how often young Black women in our cohort were told that they had an idiopathic pneumonia. People did not figure it out. And in fact, very, very treatable if found. It can be very treatable if found early, can be deadly with a high mortality if missed. So ILD in anyone at all, certainly now we're thinking, our pulmonology colleagues will tell you that they now check an autoantibody panel, which is now much more widely available, but particularly a young woman who is in a racial minority, please think about that. Okay. Characteristic rashes, the heliotrope rashes, it gets its name from the heliotrope flower. It can be on the upper lid margin. I believe you can see my cursor as well. So I hope that's true. So on the upper lid margin, but also remember it's under the eyelid as well. Just a little clinical pearl that when you're trying to decide if somebody, actually first I always ask if the person has eyeshadow on, which I've been confused, right? I ask my patients not to wear makeup to clinic, but sometimes my female patients are not willing to do that. So making sure that there's no makeup on the lid margin, and then looking from the side of the patient. You can actually see a heliotrope rash much better from the side than from looking head on to the patient. Now, this is, again, like everything, unfortunately, often described in Caucasian skin. So this can be a dark hyperpigmentation. I'll show you some examples of different skin gradations, but certainly we could miss it if it's a dark pigmented rash over the eyelid. Some people may say that it looks like post-inflammatory hyperpigmentation, but the patient will tell you that the rash is only days to weeks old. That's not a post-inflammatory process. That's an inflammatory process that we haven't learned properly on skins of different pigment yet. But stay tuned for that. I am interested in teaching that to the future generation of neurologists, rheumatologists, pulmonologists. And if you are really unlucky, you can get an intense lid edema. This is a patient who has graciously given me permission to show her picture. And I always show this one and remind myself that she told me that when you send this picture to a physician, you get a very quick appointment. And it was so true, right? So this is the most exquisite example of eyelid edema from dermatomyositis I've ever seen in my career. So again, I told you it can be kind of subtle, and I'm not sure how well this projects to you. This is a woman who actually had juvenile onset dermatomyositis, and she has tiny telangiectasias around her lid margin and a little bit of erythema. Here in this woman, she just has almost telangiectatic marks under the eyelid and above the eyelid here. Again, not confluent rash, but more of patchy. Here, this is almost like a raccoon, and that you can see some scaling as well. And then here, it's one slightly darker pigmented. This is not hyperpigmented per se. It is actually red, but it also has some darker pigmentation on the upper lids. And you can see the intense area of erythema along with scale. Okay. A few other things to talk about. So here again, I think gives you the example of what hyperpigmentation can look like on darker skin. Here, we see in a child, this is you can almost guess that you could feel that if you could touch the screen, that would be raised. Whereas this is likely raised, but could also possibly be flat. So it's the difference between Gottron's papules and Gottron-Sine. And then remember to look in the feet. So you have to take socks off of your patients. I think neurologists are excellent diagnosticians and often do a full exam very well. But one of the things that always remind my colleagues and my training colleagues is we have to look at our patients' feet. We're looking for arthritis a lot, but I've been surprised to see Gottron's papules hide on the feet. And just again, I know this is a review for most of you, but other cutaneous findings. So in addition to Gottron's papules, there's Gottron-Sine. Any extensor surface of the body can have that rash. So I always look at knees, elbows, ankles. The V sign looks like this person's been in the sun, but necessarily has not. It can be a photosensitive rash, but it need not be. So sometimes these rashes occur even when there is no exposure to the sun. This is the shawl sign. Mechanic's hands is this. And this is also a fantastic reminder to look very closely when someone comes in with some weakness, some pulmonary complaints, looking for the cracking, fissuring of their hands, particularly on the fingertips, sometimes the palmar surface. It's often on the radial surface of the digits, but can be on the fingertips. This is a menacing thing for most patients, and they'll often mention it to you because they snag their fingers when they try to get dressed or anything. It is really debilitating, and it's really recalcitrant. It does respond to prednisone, but it's difficult to treat with other immune suppressants. We often use emollients and other agents to treat that kind of thing. So looking carefully at the hands, making sure your patient is not a mechanic, which has happened to me before in a teaching session when I did not ask the patient what they did for a living. So assuming your patient actually is not a mechanic, looking for mechanic's hands. You can see calcinosis here. We see it in children, but I want to remind you, we see it in adults. So this is my patient next to this picture on the left of the calcinosis often found in the elbows of children. It's be seen on the buttocks, the thighs, abdomen, really quite frankly anywhere. We've described it in the mandible recently. This is obviously an X-ray where you can see just really debilitating calcinosis. The foot is an unusual area for calcinosis, but it does happen in our adult population. And then this is in the hip area. There's just extruding calcinosis. It actually comes out looking like toothpaste and can be incredibly debilitating. Cuticular erythema is one of the finest, closest signs to look for dermatomyositis when you're not sure and when you're looking at Gottron's papules. If you look at your own hand in winter, I mean, I can do it now, and I'm sure you can just take a moment to look at your own MCP and PIP joints, look at your own knuckles, and you're like, I could give myself a score for a little bit of a rash there. I mean, we all sort of joke that we could probably all score on the dermatomyositis scoring system. It's a little difficult to try to determine, especially if it's not that raised papular rash that I showed you. Looking at the cuticles is another way. Often, almost always, there is cuticular erythema to go along with the Gottron-Sine or papules that helps you rule that in. And if you looked up closely, there's really dilated nail fold capillaries. We also see this in our scleroderma patients, but this is seen in myositis as well. Okay, what about special rashes? I just want to highlight a very important phenotype that is often was originally missed. I think now most people know it well, but the MDA5 phenotype is specifically associated with these punched out ulcers. You can sort of see these, it looks as if someone took a hole punch. If you look at the figure on the bottom left, this actually is a perfect scarred out ulcer of a patient on the MCPs. This is a very common place for these ulcers to occur. This is on the shoulder. Again, looks like a hole punch. If you look carefully on the volar surface of the hands, you see something that almost looks vasculitic. This is actually a vasculopathy and not a true vasculitis. Again, I used to call this reverse Gottron's papules for years. And then somebody smarter than me named Dave Ferrantino and others, who's a dermatologist, figured out that when you look very carefully at rashes for a long time, these rashes were unique. And this is in our own cohort. Again, I think you can appreciate the palmar surface that have these very sort of mottled, and this is very, I think, prominent on the right side here. Really, you would almost guess that that was a vasculitis. And again, it turns out to be a vasculopathy. Important to know about these palmar changes because they can be associated at times with very severe, rapidly progressive lung disease. This is an important phenotype to know the difference. We rarely see digital loss in our myositis patients in contrast to scleroderma, but these ulcerated palmar papules, this necrosis of the fingertips can occur in this background of what we call a lividoid vasculopathy, right? So that is a very typical phenotype. So one of the things in addition to lung disease that these patients are at risk for is digital loss. This is one of the only times where Raynaud's phenomenon and these lividoid changes in the hands do lead to potentially to digital loss. What about the ovoid palatal patch? This again is a description by our dermatology colleagues. How many of us look in the roof of mouths of our patients? Maybe not so often. This is one that I want you to remember because it is helpful in distinguishing who might have cancer. So this was a study done by dermatology colleagues that looked at 52 consecutive patients with dermatomyositis, but included only 45 of them. 18 of them had this well-demarcated patch of erythema that's on the hard palate. So it's the posterior hard palate. It wasn't ulcerating, and it had what's called this white arcuate marking. And it was right in the midline. So you could see it almost like a U shape. And patients didn't know they had it. They're like, really? I didn't know that was there. Or my dentist noticed that and he didn't know, or she didn't know what that was. So the patch is significantly associated with the anti-TIF1 gamma antibody. I'll show you briefly the association of the antibody with cancer, but again, that's a 45-minute talk into itself, talking about the cancer association with myositis. But none of the 16 patients with any of the other defined antibodies actually had this oral lesion. And this lesion was associated more often in women, and they were actually more often clinically amyopathic. Now, I will say that maybe just because this was a dermatology cohort, highly associated again with cancer. So of the 6 patients, 6 people in this study who had anti-TIF1 antibody positive patients, who had TIF1 antibody, were TIF1 antibody positive, all 6 of those patients with cancer had this lesion. Now, it's not to say that everybody with this lesion has cancer, just in the other direction. So think about the posterior palate when you're thinking about your dermatomyositis patients. And if you see this, be a little bit more vigorous for screening carefully for cancer. Okay, what about amyopathic dermatomyositis? This was previously called dermatomyositis cinemyositis. We've talked a lot about this as essentially disease without muscle involvement. Just know that potentially fatal interstitial lung disease and malignancy certainly occur in this subset. For lung disease, these amyopathic dermatomyositis patients are often MDA5 positive. So just again, the teaching point about amyopathic dermatomyositis is it's really not necessarily benign. They get missed or assume that this is a dermatologist issue, but it's often really a systemic phenotype, and we need to be thinking about their lungs and cancer. I am not going to spend a long time on this because you all taught me this part. This is an old slide that when I first learned rheumatology, it said, look, this is quote unquote PM. It's endomesial, and in the inflammatory infiltrate is endomesial. In dermatomyositis, it's perimesial, and it also has a vascular or vasculopathy where there's vascular inflammation. Probably not as easy as that as we've moved on. Again, I'm going to go very quickly for this audience through normal muscle. You know this well. In polymyositis, this nice, even shape and size of the fibers becomes distorted, of course. So if we quote, polymyositis would be typically primary inflammation, which you know is normal fibers that are surrounded by inflammatory cells. They don't invade them. In dermatomyositis, the hallmark is perifascicular atrophy, but only about 1/3 of patients have this finding. And there is a brisk perivascular inflammation. I've long maintained that every subset of dermatomyositis is likely a vasculopathy. I strongly believe that is the vessel, it is the immunologic target, and the myocytes come along as innocent bystanders along the way. I don't think the myocyte is its original target. What about immune-mediated necrotizing myopathy? This is the conversation from Mars and Venus where we were saying it was just polymyositis. The patient looks like polymyositis. They come in, they have proximal muscle weakness, they don't have a rash, they didn't seem to have dystrophy, they didn't have anything else. We said that's PM, and people looked under the microscope. Our neurology colleagues said, there's no lymphocytes, really, that's not what's dominating here. That's not this, right? So you don't have to be a neuromuscular specialist to know that there are no lymphocytes or there's a paucity of them. What we do see in immune-mediated necrotizing myopathy is likely a complementopathy, where complement deposition on smaller capillaries and around the myocytes. So there are macrophages there, but they tend to be more helper macrophages. So it's likely not mediating the damage, but rather cleaning it up. So immune-mediated necrotizing myopathy, likely a complementopathy, not a primary inflammatory disease, but certainly clinically indistinguishable most of the time from what we would typically call PM. And then I don't have to tell this audience that inclusion body myositis looks exactly like quote unquote polymyositis much of the time if you're not seeing the vacuoles. If you're lucky enough to see those red rim vacuoles, fantastic. If you're not, these patients get called polymyositis for 10 years, get treated with methotrexate and other drugs, and then finally come see us and we have to unravel that story. Polymyositis is a rare disease. Okay, so you're still making your breakfast, you're walking your dog, and you say, okay, wait, this is time to tune back in again. This is a cut point where I say, please just listen, commit this to your memory. And when you see your patients that get referred with polymyositis, do this little checklist in your head for me, please. I'll go through them briefly, but immune-mediated necrotizing myopathy, I think I've beaten to death. We'll talk very briefly about what that looks like clinically in comparison. Overlap, I won't discuss today, but that's saying, do they have another rheumatologic disease? Maybe I shouldn't call that polymyositis, that's more of an overlap. And that's important because they need closer monitoring for those other phenotypic elements. The anti-synthetase syndrome, I told you, is different. And that could be true when you don't see a rash. Finally, inclusion body myositis and muscular dystrophy. So this is the quick checklist I do in my head when someone says they have polymyositis. The first thing I do is not believe it. Immune-mediated necrotizing myopathy. I told you that our neurology colleagues, I'm sure you may know Tony Amato well and Birch Griggs of IBM fame. Tony Amato is up at the Brigham, and he's often one to push the envelope. And from a study by Vandermeulen, which I'll show you briefly, came an editorial that said, look, this is as mythical as unicorns and dragons. Polymyositis really is rare. And in fact, it really is. If we look at the Vandermeulen study, we find that 32 patients who were in this possible myositis category, the worst category you can be in, possible PM, 19% of them, in fact, had a necrotizing myopathy. Really going back and finally phenotyping, most patients end up in another bucket. They are not in the polymyositis bucket. These are criteria developed by the ENMC. This is the European Neuromuscular Consortium that often meets in the Netherlands. This year virtually, unfortunately. And again, clinical criteria look identical, really very similar to what we would call polymyositis. There's an elevated CK. Laboratory criteria now include an MRI with imaging as well as our EMG typical findings, and myositis-specific antibodies, specifically HMGCR and SRP, very helpful. And again, I reviewed the muscle biopsy findings, which include sparse inflammatory infiltrates and MAC deposition. What do you need to know clinically about immune-mediated necrotizing myopathy so you can stop calling it polymyositis? Well, they actually do present with proximal muscle weakness, much like polymyositis would have been known to do. Very high CK levels in general, often in the thousands. These patients hurt. 75% of my patients tell me that their muscles hurt. They describe it as a rubber band or an intense feeling of pain that nothing helps really go away. They can't reproduce it, but it's very deep. There's extensive muscle atrophy and often functional disability. They can progress to cane or even a wheelchair relatively quickly if not treated. The muscle biopsy, of course, is the most important part. We've talked about why. We've also talked about the fact that we think that in the opposite direction of dermatomyositis, where there's not a lot of necrosis, we think here it's the muscle necrosis that explains why the CK levels are so very high. Okay, let's talk briefly about the anti-synthetase syndrome. That is a constellation or a total, it's a full body syndrome with arthritis, mechanics hands, fever unexplained by something else, interstitial lung disease, and Raynaud's phenomenon. I'll just go back again, sorry, real quick. Just to mention again, to remember that you're going to look closely for mechanics hands and that 40% of patients with the anti-synthetase syndrome present with an isolated rheumatoid-like arthritis. So maybe you won't see them first, you'll see them second, but our rheumatology colleagues often see these patients and they unfortunately often get labeled as seronegative rheumatoid arthritis for quite some time before developing the other features. IBM. You all know that this is the most common myopathy over the age of 50. Technically, you have to be over the age of 30 for the diagnosis. This is the one that predominates in men versus women. It's 2 to 1. The other myopathies are 3 to 1, women to men. Proximal strength loss. This is an asymmetric weakness, which is important. Muscle atrophy can be prominent. Really what we look for, of course, is distal strength loss. Very few things affect the finger flexors. They do, but in my world, finger flexor weakness often equates to inclusion body myositis. You can see mixed myopathic and neuropathic EMG findings, and that's also another clue for me. And then finally, in addition to the inclusions, this really gets labeled often as treatment-resistant polymyositis. You can see the incredible muscle wasting over time in the quadriceps and the finger flexors. I often remind myself that the criteria are data-driven. This is what we sometimes call Lloyd's criteria. Tom Lloyd is one of my colleagues at the Myositis Center, sees most of our IBM patients. Clinically, you have finger flexor or quadricep weakness. You guys know this well, but I always remind myself that knee extensors weaker than hip flexors, that's an IBM pattern. The other way around, where hip flexors are weaker than knee extensors, that's a different pattern. That's antisynthetase, that's immune-mediated necrotizing myopathy, et cetera. And the biopsy can be clinically indistinguishable from quote unquote PM, as we know. Hopefully we see those rimmed vacuoles. I wanted to show you just briefly, we talked about the phenotype. I wanted to show you at the level of RNA-seq expression of interferon. This is a paper by our group led by Dr. Iago Pinal-Fernandez, again, along with Andy Mammon and the rest of our crew. Here, I think you can see sort of heat mapping, recognizing that the most intense interferon signal is in our dermatomyositis-related patient groups. And then if we look at them, it's almost like a stepwise function where dermatomyositis has the greatest interferon 1 signal, followed by the antisynthetase syndrome, IBM, immune-mediated necrotizing myopathy, and then those biopsies that were non-myositis normal biopsies. Looking at that, so this is comes from that paper. I think it's a sort of a teaching slide, which I really sort of like. I've doctored up a little bit. But again, looking at muscle biopsies, doing RNA-seq, and looking at expression. This is interferon 1 and interferon 2. And while you don't have to memorize the patterns, I think it's important to say they're distinct. Dermatomyositis looks a lot like the antisynthetase syndrome in the sense that interferon 1 is highly expressed, more interferon 2 than interferon 1 in the antisynthetase syndrome, and then dermatomyositis of equivalent interferon 1 and 2 signaling. We don't see a lot of interferon in immune-mediated necrotizing myopathy, which we suspected, but surprisingly, there's an interferon 2 signal in IBM, which was unexpected. Okay, finally, muscular dystrophy. This is for you. You know this, you teach this to me, not the other way around. But again, for my rheumatology colleagues, I just say, look, think about these potential muscular dystrophies. These are the ones that are most common. Duchenne's unusual. I think only one case of a Duchenne's manifesting carrier in 20 years. Dysferlinopathy, I've diagnosed more often than I even knew what that was when I started training. That's a mimicker for sure. Myotonic dystrophy, also DM2. And then finally, FSHD. Again, that's a talk unto itself, but again, always remembering to myself to say, could this possibly be a muscular dystrophy? The timeline of autoantibody discovery is extraordinary. We didn't describe in the medical literature myositis until the 1880s. And then there's like 100-year period of quiescence and then an explosion of autoantibodies. This is the, again, in the interest of time, I cannot go over all of these, but just to say that the autoantibodies in themselves are very helpful phenotypically. I'm happy to actually leave my slides, or this slide and this one, which is dizzying, but so important. This is another commit to memory kind of thing for me. I mean, not commit to memory, but committed to your saved things to try to remember what myositis looks like today. We have overlap myositis, including the antisynthetase syndrome. We have IBM, which has 1 autoantibody, and T5C1A. We have dermatomyositis, which has 5 autoantibodies. And then we have immune-mediated necrotizing myopathy. And I don't have time to discuss all of these antibodies, but suffice it to say that between the myositis specific and the myositis autoantibody associated autoantibodies, we can often tell which bucket people sort of fall into and how we can treat them clinically. So finally, in the last few minutes, treatment. So this is a nice review from Nature Reviews from our colleagues at the University of Pittsburgh, Chad Otis and Rohit Agarwal, that reviewed the medical literature. And again, this is eminence-based. We still start with glucocorticoids and methotrexate or azathioprine most of the time. IVIG is usually reserved for pretty severe cases. We then move on to MMF, tacrolimus, sometimes cyclosporin, or a combination of the above. And then we finally move on to rituximab, cyclophosphamide, very rarely, and then corticotropin injection, repository corticotropin injection. Tapering of the glucocorticoid should be about 25% reduction monthly to be on less than 10, preferably 5 milligrams within 6 months. For anti-SRP and anti-HMGCR, again, a lot on this slide and just literally a minute to end.
In SRP, we often start with steroids, but we end up using rituximab most of the time. And HMGCR, we end up using IVIG most of the time. So the three main things that we use are a steroid-sparing agent like methotrexate or azathioprine, but often have to go to our third-line agents. These are recalcitrant diseases. When we look at interstitial lung disease, the only addition I would say is that we use maybe more cyclophosphamide or rituximab. Again, the myositis clinical trial landscape is dizzying. We went from nothing to everything. And I think I just don't show this to you for you to commit it to memory, but to show there's a lot in the pipeline. There is a lot that unfortunately is terminated because we don't see a signal. And there's tons in process, including things like endocannabinoid receptor antagonists and inhibitors of the inflammasome or the immunoproteasome, looking at very, very different ways to think about myositis. And then zilucoplan on the very end of this, I think is very interesting. This is a complement inhibitor, and this is targeting specifically our IM and M patients. For IBM, it's pretty dismal. We have arimoclomol. Rapamycin is actually gearing up, I think, to launch soon. And we did a small trial with pioglitazone, looking at the idea of expression of AMP kinase and PGC1 alpha, thought to result in increased mitochondrial biogenesis in the muscle and improved exercise capacity. Again, that's a small trial, and we don't have our results ready for prime time yet, but stay tuned. So I realize I'm at the very end of my time. Just remember that there's new classification criteria. Polymyositis is rare. Autoantibodies help narrow down the myositis subtype. Again, that could be a follow-up lecture into itself. We could talk for an hour about myositis autoantibodies, and I'm happy to do that at some point. And then finally, we really have a lot of therapeutic options on the horizon. I know that I've given you a lot to digest in 46 minutes or so, and I'm trying to be true to your time and your day. This is my village. I think it takes a village. I'm also like never aging on these slides. Someone told me I must update my my photo. This is actually all of us, I think, update our photos. So this is sort of, we started off with myself, Andy Mammon on the right of the slide. Sonia Danoff plays a critical role in our pulmonary patients, and Livia Casciola-Rosen at the bench. We originally had another neurologist by the name of Dr. Nguyen, Tian Nguyen, who has moved on to private practice, but we've inherited a whole lot of people. So I think what's important to tell you here is that everybody from neuromuscular to rheumatology to PM&R, actually, with the addition of Tae Chung, who's trained as, did a year of neuromuscular training, but really has PM&R training, reminds me that exercise is an incredible important component, which I didn't speak about today, and we are learning from each other. And with that, I know it's at the end, and I know that you may have places to go. I'm happy to stay around for a few minutes for any questions, and I really thank you for your attention.
Hey, Lisa, that's fantastic. I try to think back on the talk you might have given right after your fellowship, and it would have taken a lot less time and had way more simple slides, wouldn't it?
It would be like, we know nothing.
No, you wouldn't have thought that, because you'd have thought you've known everything. You know what I mean?
For which I still sort of tease that rheumatology is like rubor, dolor, color, tumor. You know, oncology has all of these wonderful algorithms, and we're like, is it red? Is it swollen?
Yeah,
So we have a way to go.
It's truly remarkable progress.
Thank you.
So anyone with a question can just post it on the chat, and I'll either call on you or answer the, or ask the question, or if you need to go. So Lisa, Joel Morganlander asks, can you comment on what commercially available panel do you use?
Yeah, this is a great question. And let me tell you, and again, I didn't get to speak to that, and I'm sure that someone has a bounty on my head for saying this, but the ARUP panel is one I do not currently support.
Would you say that again? I got which panel?
Oh, ARUP, ARUP. So there's an ARUP panel that comes through different labs. Do not order that one. That one I think actually has very poor sensitivity. There are two panels. The one we actually order, which may not be the one that you would want to use clinically because it takes a very long time, is OMRF. So that's through the Oklahoma Medical Research Foundation. You have to have your lab in the hospital set up with OMRF. It's getting a little faster because we send so many samples, but OMRF is by far, in my opinion, the gold standard lab. It requires, immunoprecipitation. It takes a long time. It's done by hand. The other one is Urimmune, and that's the one that most labs are now using. And Urimmune is probably
Lisa, how do you spell that?
EUROIMMUN,
Like
Euroimmune.
Euroimmune, yes.
Euroimmune. Yeah. Sorry, I hope you can hear me. Euroimmune is commercially available. It's a rapid precipitation panel that can actually be done. It's done in mass. The problem with that, and I didn't have time to show this data, you could actually look up this paper that we've done, is the cutoffs are probably a little bit wrong. Sometimes it overcalls some of the antibodies. So it's an imperfect substitute, but it's okay. The third one you can use is RDL, and that is out of Santa Monica, I believe it's still in California. And again, sometimes you're at the mercy of the lab. So the one thing I would say is, regardless of what panel is sent, of those three are probably the best ones that I could speak to. Your lab may, and Mayo does, I think Mayo does an in-house panel as well. We don't usually get that one, but people that come for us that have had an opinion at the Mayo Clinic sometimes actually have the Mayo panel. So I believe they may have their own in-house immunoprecipitation, autoantibody kit. What I would say is, if the antibody doesn't match the phenotype, question it and either check it in a different lab, or actually, you can call me and we can try to check it in our lab. We also do our own immunoprecipitation testing when we don't think the antibody fits. So part of it is really saying, like, some people will come in with an SRP antibody and they have a CK of 44 and they're not weak. Somebody just checks a panel and I'm like, it's not likely you're going to develop this. So some of what we end up doing is reassuring. I really usually see it that way, where the autoantibody is falsely positive than falsely negative. So probably the two most missed antibodies which are falsely negative are MDA5 and SRP. SRP is a hard antibody to pick up for some reason, and MDA5 is interferon inducible. So if it's not done in the right fashion, MDA5 is often undercalled. So that's a lot of information for you, and
it's great. So Lisa,
yeah.
One more question, which is a two-parter from Ed Smith. How do you use MRI? Specifically, how does it change what you think?
Yeah.
And do you prefer open or needle biopsies of the muscle?
So we prefer open biopsies. The second part of that question is, in order to see architecture, we really do open biopsies. I do think more and more people are doing large, core needle biopsies and getting a fair amount for studies where we really just need RNA, for example, or we're looking for molecular phenotyping. Then we do needle, and which is a lot easier to do. So, and only some people are trained to do that, and no rheumatologists are trained, although in Sweden, for example, the rheumatologists do those. So we have very few people with expertise for needle biopsy, but it's really nice for studies. But for diagnosis, open. For MRI, use it in two ways. We use it at entry to sort of just get a lay of the landscape of how much edema is there. So I use it for diagnosis. I use it for biopsy localization, because if they have patchy disease and you're going into the rectus femoris and you're sort of, we have these great examples of, you can see where the biopsy was done right like next to the inflammation, and it was called normal. So to localize biopsy site, to quantify disease in the beginning and to see how widespread and where it is, we usually only use an MRI of the thighs. So we do a bilateral thigh MRI with T1 and STIR imaging without contrast. So it's bilateral T1 and STIR thigh without contrast. Then I often use it if I'm confused, where the CK looks normal in dermatomyositis, but the person is weak. Then I'm trying to figure out, is it a steroid myopathy? Do they have cancer? Is there another reason? Is there something else going on? Or is there, in fact, a lot of edema there that's not showing up biochemically? That's a great use of MRI to sort of, and I don't have time to include it, but the most famous sort of in my mind example of this was a gentleman I saw on Christmas Eve. And he had this weakness that was so dense. He had actually had a colon cancer tumor that we found. He had SAE antibody myositis for dermatomyositis. And he was like, gosh, I'm so weak. And I'm like, he must have like critical care myopathy, something else. And in fact, he didn't have any of those. He had rip-roaring dermatomyositis, where every muscle on MRI was edematous, and his CK was 48. That's a long answer, but that's how I use it.
Lisa, that was an absolutely fantastic talk. And it's been remarkable watching the field grow, along with you or because of you. So Thank you so much and stay safe.
Thanks for being my advocate. Thanks to everyone, you all as well. Hope to see you in person one day soon.
Bye-bye.
Bye-bye.